So once again, I welcome you, and let's have a lovely few days together. Kshitij, let her roll.
Yes, thank you, sir. Thank you, sir, for that welcome message. I would now like to invite Dr. Swapnil Kenny, who is the Secretary, Honorable Secretary of the Bombay Orthopedic Society, to say a few words and welcome you all. This program is done under the aegis of the Bombay Orthopedic Society, as Dr. Asim Parikh just mentioned. So over to you, Swapnil.
Thank you very much, Asim Parekh sir and Kshitij for having me here. Uh, I am not somebody who believes in formalities, so I'm not going to really stand between you and the program. All I can say is that Dr. Kshitij Chaudhary has really worked hard to make this a little different from routine courses so that you get the experience of learning something which you probably would not have done in an advanced spine course had it been a physical course. So he's tried his best. We've had some pre-course discussions. I'm told we are having this pre-course workshop and we are going to have a wonderful course. I welcome all of you to the course of the Bombay Orthopedic Society, and I wish you very happy learnings from all the wonderful faculty who are going to be a part of this course. Thank you very much.
Thank you, Swapnil, for those encouraging words. So we'll move on. We have 1 hour to show you what Surgimap can do. So the way we have planned this for you is to have you set up Surgimap on a different computer and have Zoom working on a different device, uh, not on the computer that you are going to use Surgimap on. So I hope everybody is comfortable, because we are going to ask you to do these steps along with us. Like the way we show you the cob angles and other things, you will practice that on your computer. So you will have to see the Zoom screen and the Surgimap and your Surgimap screen simultaneously. So that's how we are going to do. And what I am going to do, I'm going to give you a brief introduction of Surgimap, and then Dr. Amit Sharma is going to take you through all the different measurements and angles and deformity planning that you can do with Surgimap. So I'll start my screen share first. Is that okay, Amit?
Yes, please go ahead, Kshitij. Thank you.
So here, so can you see my Surgimap screen now? That's what I am sharing right now. So people, the participants can unmute themselves and let us know if they are facing any problems, because this is supposed to be an interactive, informal kind of meeting. So if everybody is on the same page, I hope everybody has registered and created a free account and are able to see the Surgimap screen this way. So, all right then. So I'll begin. So when you open Surgimap, you are going to see this first screen, and this first screen, there are three areas of the software. The first one is import, the second is database, and the third one is measure. I'm going to show you the first two, and Dr. Amit is going to show you the measure part of it. So if you click on the first part, that is the import, this shows you an import screen where it allows you to import images from outside Surgimap software. So you can, we have already shared with you on Dropbox certain exercise files. So I want you to put those exercise files on your desktop, or remember wherever they are, open that in your Finder or on your Windows Explorer. And let's take one of the patients, let's say Vicky Patel, and all these patient names have been changed and anonymized. So just take the folder Vicky Patel and drag and drop it into this box here. So let's say I've dropped it here. So once you drop it it is going to show this screen, and there are 5 images in that folder, and the patient's name has already been picked up in this patient details, because these are all DICOM images, and because they are DICOM images, all this data is inbuilt into that, into those images, and all you have to do is say import or import and find in database. If you click on import, it will take you back to the import screen. So let's import another patient here. So let's say we import Nisha Shah. So drag and drop the folder that containing the patient Nisha Shah into this box here and let go. So you will see that this folder had 4 images, and because these images are JPEG images, you will see that Nisha Shah is not seen here as a patient name. So what we will do is name this patient as Nisha Shah. You can put patient's email, birth date. Let's make this patient female. You can add study details saying that these are x-rays standing or whatever they are, and study details, more information, and collaborators. So all that information you can put here, and then instead of clicking import, say import and find database. If you click that, it will take you to the database part of the software, where Nisha Shah is highlighted and you have the images seen here, right? So let's go back to the import area and import the other patients as well. So I am taking in, so import all your patients. There were 5 patients that I had shared as a exercise file. Drag and drop them here and import them into the software. So Sachin Patel, again, this is a DICOM image, so it is taking up the name automatically. So I'm going to hit on import. So we have 3 names already, and then I'm taking Jyoti Singh and Kavita Patel as well, and dragging them. I can select multiple folders and put them here like this. I don't necessarily have to take one at a time. So this will automatically import all these images. That Kavita Patil is a CT scan, so that's a little larger image. So it will take a while to import. So just give it some time, and it will import. Till that time it is importing, I just want to ask all the delegates if anybody is having difficulty.
Yeah.
Either
How to
unmute
import the picture? He
or
says
the chat.
imported it from the
You download it. Which patient?
all the patients one after the other.
They're
Import.
here already.
How to drag it there and put it.
If you have, some of you may have already imported them, that's fine. If you have already imported them, then you know already how to do this.
You imported already.
Those who haven't
I
imported it, put it in the software. So if anybody has questions, keep your chat window also open. There are other people among the faculty members who can help you also. So Dr. Chirayu is there, Dr. Dheeraj is
Where
there.
is there? How to get this?
Dr. Ranjit is there.
Click on the patient.
Only 4 patients were there yesterday.
Yeah.
I think someone
they added more
mic is,
patients.
I'm just going to mute them.
Dr. Kshitij?
Yes.
Yeah, I'm Ranjit.
Yes.
I was trying to do it. I'm not able to import the complete folder. You should do it picture by picture.
What does it say when you import the complete folder?
So when I downloaded the thing which you had sent onto the desktop. So when I go to each folder, the subfolder opens up. I see Jyoti Singh. I can see the PNG image which you have loaded, right? So I have to individually load them because I get the save icon on the right side. Dialog, DJ, cancel, and save. So when I save, it goes into the import page, right? When I go to the next page, next patient, it only takes one by one image, not the entire folder.
That is okay. As long as you drag the whole folder into that area, the whole thing will get imported. Whether you are seeing different images or just one images, the whole thing will get imported.
Because I'm not able to drag it. It says just save, save, save. I think something wrong at my end. Okay.
No. So save what?
Save the image. So I'm not able to save, for example, Kavita Patil. I'm not able to drag the entire folder.
Kavita Patil is a CT scan. It's not a single image.
Okay, so the entire folder doesn't, I'm unable to drag it.
So just skip Kavita Patil. Try Vicky Patel.
Same, Wikipedia again, when I click on it, I see all the three. I think it's a full length X-ray, right? So I'm unable to drag the entire thing into the
So are you dragging the images or are you dragging the just
folder.
folder?
I'm trying to drag the folder.
When you drag the folder into the import area.
So when you go in there, it opens import, click here or drop images, niche desktop, download, hospital packs is aata hai, right? So there when I go into that thing, I say go click here to drop the images, right? So when I go to click here, it opens my desktop, which shows the BOS Surgimap Scoliosis folder. So in which I am seeing all the subfolders.
Okay.
So when I try to get, like say Vicky Patel, when I try to right click or left click, the entire the subfolder opens up.
You are not okay. You are using this click here like that.
Yes, that's right.
Okay. So why are you not dragging and dropping the images there?
I'm unable to drag it. When I try to drag it, the subfolder opens up. This is something in my.
You are using what?
I'm Surgimap 2.3.21 on a Mac.
But which operating system is that?
Mac. The OS is the what do you call the latest? Which one? Mac Big Sur. Mac OS Big Sur.
Also, it's the same one that we are using. So you.
Okay, go ahead. I think
So,
I'll find out some way out there.
Just try, or at least for now, take individual images and import. That's fine. Right. Vicky Patel, you can import individual images.
Okay.
So you are doing like this, right? The way I'm showing you.
Yes, that's right. And
then you click on this and then say save. Correct? That's what you are doing.
So when I do that, I get the subfolders opening up. It doesn't save.
In mine, I have already imported the patient, so that's why it is showing like that.
Got it.
Let me see. Let me delete this patient. So is anybody else having a difficulty getting, because we can't proceed unless you have the patients inside your Surgimap. Okay, this upload is taking quite some time because Kavita Patil is a CT scan. Let it go on for a while. So till that time, just asking if anybody faced the same problem as Dr. Ranjit. Did anybody face the same problem as Dr. Ranjit?
The one issue which I am facing, Kshitij, is that the interface which you are getting, even though you are using 2.3.2.1, and my software is also saying the same numbers.
Yeah, it is a little different.
Yeah, it's different. I don't know why. And yesterday also is like, the lines were also kind.
Yeah.
So
I think
don't know.
Something to do with the operating system, and even Windows guys will see it a little differently than what we are seeing.
So I have Catalina, so that's I think quite recent one only. Still, I don't know why it's, and it doesn't say Globus anywhere in my system.
Yeah, even I don't see that.
That is because I'm on premium version.
Okay.
So so that may be the reason, because again, premium version is not a paid version. You just have to request for it. So you go on their website and request for a premium version. They'll take your details and then they will allow you on your account to use the premium features. It's not a paid feature. It's just called a premium feature. I don't know why they call it a premium feature, but I have not paid anything. But in my Surgimap, I can manipulate CT scans. Whereas I think the ones that you have downloaded, you can just do X-rays. But that's a free feature. You can again visit the website and ask for a premium feature, and they'll do it for you, free of cost. It's not charged. So I'm
this
just
is Dr.
getting,
Vishnu.
I mean, at least I need to upload the CT scan into my Surgimap before we proceed. But if anybody else is finding difficulty getting the CT scan, just skip it. Don't take the CT scan in your Surgimap, just take the other folders inside. The CT scan is Kavita Patil. Don't take the CT scan, just take the other ones.
Yes, Dr. Vishnu, you are saying something.
Yeah.
Sir, see, I was able to add this patient Vicky Patel, but the next button when I click import, it's adding all the content under the same patient ID. I'm not able to create a new patient subfolder kind of thing. in Surgimap.
Which patient did you take next from Vicky Patel?
From the first one I created Vicky Patel.
Huh.
After that, when I'm selecting any other patient, I'm having difficulty.
So it puts the patient back into the same patients.
It is
You have to change the patient details. If you are taking the JPEG and the PNG files now, they don't
yes,
have
sir.
DICOM information in them. So you have to rename them.
Okay. I'll try again.
So
No,
some
no,
of
I
the
think the issue he's facing, Kshitij, is that once you have imported the images for a particular patient, at the very bottom of it, on the right hand side, you will have to click on import and find database. Unless you do that, you will be just seeing the images in the system. They are not yet imported. And once you click on that, and then you will be seeing them in the database, and then you have to go back to the import again, and then you get the new patient.
Yeah, correct. So by just dragging it, they won't get imported. You'll have to click on import for you to be
Okay.
see them. Unless you click import, they will not be seen.
Sure. I got it.
Okay.
Okay. Thank you.
So here, like I put Kavita Patil and that other patient, Jyoti Singh, in the same, dragged and dropped together. So they got bunched up together. So this is a CT scan of Kavita Patil, and this is a X-ray of Jyoti Singh, because that's a JPEG. It doesn't have DICOM information. So I'm just going to delete this from here because I dragged them together. So I would say the best way is to drag each folder separately rather than putting each folder together. So I'll again import using Dr. Ranjit's technique, where he said import, then said click here, and then it opens this dialog box where you have to take the computer to the place where the folders, the files are stored. So my files are stored here. So I'm going to take Jyoti Singh and then say save.
Good evening, everybody. I think that is a longer way of doing it. I
Yeah,
think it's
that's a
easier
longer
to
way of
just
doing
drag
it.
it.
It's best is to drag and drop.
Kshitij, try a different folder which has multiple images, and let's see what happens then.
I have already imported. Now, if everybody has imported, we'll go ahead. Otherwise, we'll get stuck here only. Is at least few of them have you? If everybody has imported, then we'll go ahead. Because there's some problem with this only. The what I think Dr. Ranjit is facing. So I am going to just drag and drop.
It's okay, Kshitij. I have kind of got a couple of images. No, wait. Let's go ahead.
You've got couple of images is good enough. So
Fine. We'll go ahead.
If most of you have got the images in, just put in the chat box so that we know that you have got it and you can import. So I just drag and drop like the previous sir just mentioned, that's an easier way of doing it. And I'm going to make this patient, Jyoti Singh, and then say, unless you click import here, you are not going to have it in the database. So you have to click import, and then you're going to get a message like this that the thing is imported. So once you have done that, let's move on to the database part of it. So the database is where all your patients are stored. In this, you can see there are 5 patients here. And then in the thumbnails, you are going to see those patients here, and these are some of the patients' details. And so let's, if you want to go to the measure, then you can go from here and then click on the patient's thumbnails and go to the patient where you want to do all the measurements. So I think we can start with Nisha Shah. Is that okay? Everybody
Yes.
has Nisha Shah on their database. So just double click Nisha Shah's series here. And then once you double click that photograph, you see the measure part gets highlighted here. See, the measure part is highlighted here. So now you are
From
in the
there,
measure
the
part of
input
the,
you have saved it.
sorry. Yeah. So now once you double click those images in the database, it will open in the measure part of the software, and this is where you do all the measurements. So just to give you an overview of all this is the image, the AP image that is uploaded, and there are a lot of functions there at the bottom. So the first one inverts the image. Some people like to see it like this. Some people like to see it like this, whatever works. This one is brightness. You can make the image bright. You can make the image dark. So change accordingly the way you find comfortable. This is contrast. You can change the contrast more or less. This is, sorry, I made it too much. So again, these tools are all just to manipulate the image. This will maximize the contrast. This is auto level. So this is automatically, again, auto level is making it all weird. So I think I have made my picture all, it was fine in the beginning and I messed it up. But yeah, so you can improve it by changing all these parameters. So let me make it a little better. Okay, so this is good enough. Now these things are to rotate the images. These images can be rotated. Again, this is something which is more used for sagittal adult deformity planning, where you can rotate the images, which is required for planning posterior column osteotomies or something like that. But that's not the topic for today. Then you can flip images vertically. Most of the time you don't require to flip images vertically, but you require to flip images horizontally, because by convention scoliosis x-rays are right side on the right side and left on the left. So a typical right-sided thoracic scoliosis in a girl is going to look like this. The moment you start seeing curves like this, you start wondering whether this is idiopathic, because a left-sided curve more often than not may turn out to be non-idiopathic. Okay, so it is important for us to understand patterns just visually. So by convention, x-rays are like this. So most of our x-rays in the radiology department are going to give it like this to you. You can see the R written in the correct way, and this is how they are given to you. But what we do instantly is you have to flip it and then do all the measurements, because by convention right side should be on the right side of the image, and that's why you see all these letters are also inverted. But this is how you should keep it, and that way you can get it. So now another important function is the change zoom, where you can zoom the image up and down, and for you to pan the areas, you go to this mini map here and then move the mini map to wherever you want to see it. So this minimap moves the zoomed image to where you want to see it. Okay. And if you want to quickly zoom out, then click the button next to the lens and it will quickly go back to its old position. So again, zoom in and minimap you can move, right? So that is about this. This is reset. So I can reset and go back to what it was originally. So if you have messed up the images using contrast and brightness, you click this and you can go back and modify layout. You can keep two images side by doing this. But right now we are not going to have two images. So let's leave at that. But if somebody is not able to see the minimap, if somebody has a problem seeing the minimap is sometimes here. You can see there is a minimap here. If you switch off this minimap, it will go away. So make sure that this part minimap is kept on, right? So that's about this area.
Excuse
And
me,
then,
Dr.
yeah,
Yeah.
sorry.
Can you just again say about minimap?
So minimap, you are able to see minimap, right?
Yes.
So sometimes the minimap is not seen. If it
Okay.
is not seen, it is because this is switched off. If you switch this off, you won't be able to see the minimap.
Okay.
So make sure that the minimap is kept on.
Okay, fine.
By default, it is on. So you
Okay.
don't have to worry about it.
Okay, thank you.
Okay. So this is a very important function that you are going to use, the zoom. This minimap, moving this and go back to its original place. These three things you will use maximum when you are doing the measurements. All right. So just know about those. Most importantly are those. And then on the side here, you can see that there are 4 areas: help, tools, measure table, and surgical tool list. What we are going to use are the first 3. So help tells you step by step how you are going to do the measurement. So always keep the help on. Don't keep it minimized, otherwise you won't see it. So always keep the help on so that you know the tool. And then these are the tools. And then these are the measure table. So whatever you measure comes here. It comes here as a table, right? So keep this on and reduce your surgical tool list. So you can see that there are various tools here. Uh, Calibration and all these things are written. And then this is lordosis, SVA, okay, chin vertebral angle, cob angle. So if you are not seeing any particular measurement, by default, some of them are hidden. So if some of them are hidden, say, let's say if you are not able to see one of them, like say if you are not able to see angle here, then the reason why you are not able to see angle here is because in this settings button, it is not checked box. So if you click on the setting, you will see whatever area, whatever tools are visible to me are check boxed. So I'm not seeing T1 spinopelvic inclination because it is not check boxed. And if I'm not going to use it, I'm going to check unsee it. So I don't want to do rib vertebral angle difference. I'm just checking that off. So I won't see the rib vertebral angle difference here. So if you are not seeing anything particularly, then that's the reason you are not seeing it. So let's say if you put your hover your mouse on cob, it will tell you in the help area how you are going to measure the cob. So keep the help and the tools visible to you, right? And before I hand over to uh, Amit, one quickly, I'm going to show you how to calibrate the image, because this, remember, Nisha Shah's image is a JPEG image or a PNG image. It's not a DICOM image. So this is not a calibrated image, but fortunately I have taken the screenshot of this image from our hospital packs, and our hospital packs always uses a scale next to the x-ray. So make sure when you are taking screenshots, you include the scale. Okay, so this is the scale. Now from this scale, I know that the distance between these two long lines is 5 centimeters. So what I'm going to do is click on the calibrate an image button, and it is going to say, please draw a line over the calibration marker, and you will be asked for its length afterwards. Click on OK. Then click on your calibration marker from this line to the longer line here, and say that this distance, it will ask you, how much is this distance? This distance is 50 millimeters or 5 centimeters. So 50 millimeters. So once you say that this line is 50 millimeters, it has calibrated this image, uh, and you can actually do the distance measurements. So if you take the line tool and do the distance, you will be able to actually measure the distance between 2 points. If you don't do this, it is just going to draw a line and say that this is a non-calibrated image. So if you want to measure the distance of the say vertebral end plate, then you can draw a line here and it will tell you that this is about 40 millimeters. So that's how it works. I'm going to delete this and I'll hand over this to Dr. Amit for the next part. So Amit, over to you. I'm going to stop my screen share.
Thank you, Kshitij.
So I hope everybody has listened to Dr. Amit's talk in the Google Classroom. Just give me a minute to stop this screen share. I'm sorry. I'm sorry. Okay, go ahead, Amit.
Thank you, Kshitij. So, so I have actually imported this patient Nisha Shah, and as we can see, we are seeing the patient from behind. So right is on our right side and left is on our left side. So we'll go through like angles one by one, and we'll start with the sagittal plane. Kshitij, is it seen properly? Everything is okay?
Yes. Yes.
So we'll start with the sagittal plane alignment first, and in case anybody wants to see any particular angle, or Kshitij, if you have any suggestion in between, just please stop me and let me know. Okay. Now there is one difficulty, like we don't have all the angles here available on the right hand tools. So for some of the angles, we have to kind of improvise and use the other thing which is given and kind of utilize it for the angle which is we want to angle or the alignment which we want to measure. So let's start with the CSVL, central sacral vertical line. Now, if you'll see your tools on the right side, there is no CSVL measuring tool over here, as you can see over here. So what we have done yesterday, me and Kshitij were kind of talking about it, and then so let's enlarge the image a bit. So basically, what is CSVL? CSVL is a vertical line parallel to the edge of the lateral border of the X-ray, starting from the midpoint of the sacrum and going up. So what we can do, there are many ways we can do it. So one way of doing it is that we can take this let's take this angle line, and then we make one line which is kind of parallel. Now another important thing, so when your line is at 0 degree at horizontal, let me bring it up and show you properly. Can you guys see that this is turning into pink? Is it visible, Kshitij? Hello.
Yes, it is visible, Amit.
Yeah,
okay.
It is visible.
So what you are seeing here is a pink line. Pink line means it is 0 degree. It is perpendicular. It is like parallel to the floor. So what we need to do, that we have taken an angle for measurement. So what we need to do, we need to go to the center point of the sacrum, and then just make a right angle line going up from it. So here we'll have to do a little bit of guesstimation, and we kind of because it doesn't show the angles live. It will show once I leave this point, leave the cursor, and then it will show me the angle. So let's leave it over here and then see. So it is 90 degree. So when it is 90 degrees, so this is my CSVL. And I'm sorry, I did not calibrate this one. So let's calibrate also quickly. And I go from here to.
Amit, can I ask you something?
Yes,
Hello?
please go ahead. Yes, please.
Yeah. Is CSVL defined as a line drawn parallel to the accept plate, or is it a line which is perpendicular to the line which is joining the base of the superior facets of S1?
So basically, the thing which is happening, that it's difficult to see those facet joints here on the X-ray.
So that I'll answer that. the old concept was to do it perpendicular to the pelvis.
Yeah.
That was the original description in the King paper. But the problem with that is that a lot of people have slight pelvic obliquities that are not consequential because of some amount of limb length discrepancy. So up till 2 centimeters of limb length discrepancy is generally ignored. It doesn't count towards the deformity surgery planning. So what is being done now is that you measure the CSVL from which is parallel to the edge of the X-ray, provided that you don't have a pelvic obliquity that is more than 2 centimeters. Because if it is more than 2 centimeters, then you will have to keep a shoe raise to reduce the pelvic obliquity and then do all the measurements. Otherwise, everything will go off. So that's the reason why the central sacral vertical line is now defined as something that is to the edge of the X-ray, which is perpendicular to the floor rather than perpendicular to the pelvis.
Yeah, but
So
is it like accepted by SRS?
Yes.
Yeah, it is in the.
It is accepted by SRS, and there are only 2 mistakes in Lenky paper. There are only 2 mistakes in King's paper, which Dr. Lonstein asked me to search for and tell me in the clinic one day when I was a fellow. One of them was this, because that's not practice. And the other one is a thoracolumbar curve in one of the photographs.
We had lost you, Kshitij, so you have to repeat again.
Sorry. So one of the problems, the mistake in the drawings of the King's paper is this measurement of the central sacral vertical line. That's one of the error in the paper. And the second error we'll maybe discuss in the classroom, but that was the problem because many people have slight pelvic obliquities. So if you start taking from the highest point of iliac crest and drawing lines, now many times they are not the true representation if you have slight obliquities. Because by trigonometry, by the time you reach the CS at the top of the spine, that difference is a lot. So that's why it's taken from the edge of the screen so that these minor errors are not accounted for. But if there is a major error, then you have to actually take the X-ray with a shoe raise. You cannot do deformity planning with a pelvic that is kept very oblique because of a limb length discrepancy. That's the whole idea.
Yeah, but that will not represent the actually the vertical axis of the body.
Correct. But
yeah,
it is for
what you said is,
yeah.
say one thing is, it's like you are having a limb length discrepancy or the apparent lengthening and the true lengthening, like what you measure in hip deformities. When the person actually stands and you see the actually vertical axis, this is almost like we are taking an erect fin and we are measuring it parallel to the lateral border of the X-ray. That's 90 degrees. So that's fine, acceptable. But then raising the height will again.
So what they are assuming is that factor has been taken into account while taking the X-ray. That's what they are assuming to be true.
Ashok sir, another thing that they mentioned is a intercrystal line. What Kshitij also said, perpendicular to intercrystal line will be the one which they thought for before.
No, that is what we were. That is what we have been using it for so many years.
Yes. That's been perpendicular to it. So either way, I got your point. You are saying parallel to the X-ray rather than that it's an intercrystal line. But again, as Kshitij said, it's up to 2 centimeter. If it's more than 2 centimeter, then whole thing changes.
Then you have to change the measurement.
Then you have to actually put that shoe raise and kind of try to square the pelvis, and after that you take the X-ray. So again, you are assuming that all those things were done when the X-ray was taken.
Okay. Go ahead.
There is a very good radiographic manual put out by SRS, which I have shared on the classroom. So if just for people who have not seen it, download it and keep it with you. That has all the SRS recommendations of all the measurements.
Either in the group, you put it in the group?
Classroom.
It's in the classroom.
You were a teacher on it, but I think you have not accepted it. So if you just accept the invitation, you will be on it.
On the mail.
Yeah, on the mail. Yeah. So, okay, Amit, go ahead.
Yeah, so second thing, we'll see the C7 plumb line. Now for the C7 plumb line, we need to know the center point of the C7. So there is a method which I assume that most of the delegates must have gone through the booklet provided. There is a particular method to find the centroid of any vertebral body or a disc. So ideally what you need to do, that you need to draw a upper and lower lines parallel, and then you take the center point of them and you kind of connect them. Similarly, you do the parallel lines vertically on the right as well as left side. You take their center point and you connect them. And this intersection of these middle lines will be the centroid of any body, or for that matter, a disc. Now here we tried to do it yesterday, and it was requiring lots and lots of steps, like at least 10-15 steps to just to find the centroid. So what we finally thought that probably, you know, like we can just enlarge it and we can try to guess where is the central point of the body, and I think we can almost pretty much guess like it will be starting from here. So again, for this we'll have to take the angle. This time what we can do, we can just go to the upper edge of the vertebra, upper edge of the the X-ray line. Again, you see how the line is turning pink, so that is horizontal, and I leave it over here. And then I come to the C7 center point, and from here I'll draw a line, and so here it's good.
You can
Good
use
thing.
the minimap to go down. Don't click. Use the minimap to go down.
Yeah, one good thing that what I'm seeing is that it's showing the live angle also. So basically, let me. So that's
Reset the zoom so it will be easier.
90 degree. So I think up till over here it should be okay. 90 degree, because what we need to do, like for the thoracic shift, we can use this C7 plumb line, and to check for the coronal shift, coronal imbalance, we can use this line. So that's here we assume that this is a C7 plumb line. Now if you want to know the coronal imbalance, how much is the body shifted to one or the other side, what we can do, we can just use this enlarge it a bit, use the line tool, and because I just calibrated the X-ray, and I will try to find out the distance between this line to this line. And so let's see, this is 8.8 millimeters, so like that much is the coronal imbalance to the right side. So that's the three things. Sagittal balance, I think, will come on the lateral X-ray.
I think at this point you can just anything. If anybody has a problem, just tell us.
I hope everybody is kind of following this and they're recreating it on their
Sir, how
screen
do we
also.
delete these lines that I drew by mistake?
So you can just click it and then press the delete
Sir,
button.
how do
So
we
like
remove the lines that I drew by mistake?
So you click the line and then you press the delete button.
There's another way. You can go to the measure table and right click on it and delete it. So that same line is there on measure table as well.
Hello.
Hello.
Sir, if you draw a line by mistake, how do I delete it? I'm not able to get it.
You click on it and then press the delete button on your keyboard of the computer.
So when you click on the line, you see those red dots that appear at the next in the line. There are red dots that appear at the end. That
like
means
here.
that line is selected.
Okay.
And in fact, you can remove those angles also. You know, that will make it a bit more neat. Those whatever written, no, angle 90 degrees or all those things.
So that name we can change, because we need to give it some name, what it is. So like here, so we will have to give it some name. So actually here we can come in the measure table. We can come in the measure table and double click here, and we
Amit,
can
just
give it.
zoom out fully, Amit. थोड़ा और zoom out कर.
He is fully.
बस इतना भी नहीं. हाँ, yeah. Okay, so that everyone will understand. We have drawn a line parallel to the lower end of the X-ray. Yeah. Okay.
So you see in this patient there is a slight pelvic obliquity. Slight, very slight. But we'll see that when they measure it. So
you will see that my fonts are quite big. So what I do, I go to the settings, I go to these measurements, and then I'll reduce the font size because they are looking very big. So that's like I made it 12. Settings saved automatically. I come back to the measure here. So maybe the next one which I'll type will be looking a little smaller. And then here you see that this angle 2, what we don't know what this angle 2 is, or we can kind of click over here and then say C7 plumb line. Now this is actually an angles. We don't need miss. Let's see whether we can delete it also altogether. And
the whole angle will get deleted.
no, so angle is still there.
Oh, okay.
And
The
so
name.
that's the name
No,
is gone.
No, you will have to double click on that angle. Then it will just double click only on
What I'm as you said, na clutter. Some clutter is over there. So what we can do, we can just click on the name of the angle, and then here like angle 2, and I click here, and then you see angle 2 is gone.
Yeah. Okay.
So that is one trick, but for that you have to come to this measure table section of the to the right side screen. Now I think the sagittal things we'll see in the next setting, like sagittal balance and all. So apical vertebra or disc, we have to enlarge it, and then the most horizontal one. In this X-ray, I think what we can see that the disc, this particular disc is the most horizontal one, or maybe this vertebra. So one of them can be chosen as apical vertebra or apical disc, and that center point of will be used to take into account the apical vertebral translation. Suppose we take this disc as the apical disc. So again, we can go to the line tool and line tool.
Yes.
Or we can separate it also.
Yeah, you can separate. Put it back below tools. It will be convenient.
Yeah. So anyway, we'll do it. So I click on the line, and then I come here, and then like C7 plumb line will use to check for the thoracic shift. So I take into account this center point of the disc here, and then I go, I make again this horizontal line, so that will be perpendicular to this C7 plumb line, and I drop it over here. So 64.6 millimeter is the apical vertebral translation, and same thing we can do for the lumbar part also, and that will be in relation to the central sacral vertical line. In this case, we don't need that to do, but if required, then that central sacral vertical line can be utilized to check for the lumbar vertebral translation. And vertebra.
There is an example of a double curve where you can try it yourself, which I have shared. So there is an example of a double curve where you can do it on your own. Just the apical vertebral translation of the lumbar curve is from the central sacral vertical line, and of the thoracic curve is from the C7 plumb line. That's the only difference.
So for the one who wanted to ask how to delete them, so I'm clicking on this line right now, and then I'm pressing the delete button. So it's gone.
Kshitij, can you just highlight the how to measurement, or to you said okay, calibrate it? Just a few moments if you can.
So yeah, I'll show you right over here. So basically, let me just zoom out a bit. So basically, Kshitij has taken this picture from the computer screen where the calibration tool was in place when he took the picture from the computer screen.
Yeah, okay.
So now there is this calibration tool. You click on it. We know that these smaller lines are 1 centimeter apart or 10 millimeter apart, and these bigger lines are 5 centimeter apart. So maybe if you want to be like perfectionist, then you enlarge it. You click over here on one of the line, and then you go to the next one. So this is, we know that this is 5 centimeter or 50 millimeter. Once you're done that, you leave it, and then it will ask you like, what is the, now because see here, I don't know whether you can see that or not, because I have already calibrated this one. You can see that it's already telling me that it's 49.5 millimeter, almost 5 centimeter.
Okay.
So, but if you have not done that, then you'll have to put that value here that this is 50 millimeter apart. So then it will take into account this entire X-ray, like what is the distances for between two particular points.
So another trick is whenever you get X-rays done, put a coin on the X-ray of which diameter you know. So at least you will get some approximation. It's not accurate because there is a distance between the patient and the X-ray film, so that there is going to be some amount of magnification error, but you will get some idea at least, because the coin's diameter you know, and you can do that measurement here.
Apical vertebra, I'm going as per your list, Kshitij. Apical vertebra is, I think, again, you have to judge with your eyes, like which vertebra or disc is most horizontal, and then you have to take that vertebra into account whenever you are measuring apical vertebral translation. End vertebra is the most.
Amit, just show how to write a text to show the apical vertebra, or maybe
So,
write a text to say T12 vertebra.
So here again in the measuring tools, if you come, there is this.
Next to calibration, upper.
Yep.
Amit, can
Text
you thin
button.
out the line? Possible? जैसे ये font कम किया वैसा?
क्या चीज? You can thin out or thick out.
Lines.
So again, you go to the measuring tool here. So sorry, the settings, measurements, and you see line thickness. Line thickness you can reduce or kind of increase. So let's make it 2 for the timing. So here you click on the text, and suppose I want to like for my future reference, I don't want to kind of count every time. So I counted once 5, 4, 3, 2, 1, and this is T12. I click here and I type T12, and then I put it in the center so it will not interfere with any of my measurement, and that's T12. So that is now will be there permanently. Similarly, I think with these lines also you can, I mean, if you really want to put some markings here, you can put a some text next to it and then define them like what this line is for.
You can change the name of line 2 to say C7 plumb line. Right click on it and change it.
Yeah, I think I just double clicked it, C7 plumb line. Here it is. So end vertebra, I think you have to just, otherwise the other method by which you can do if you are really confused, you know, which vertebra to take into account, then you can actually use the angle tool and check the angle of a vertebra. Suppose I am confused between this vertebra L1 or L2, which is the end vertebra. So maybe I can use this angle tool, and in reference to the horizontal, right now suppose I make it here, I put a line over here, and so this one is telling me 34.1, and let's take this line to the next one, and I'll have to readjust it a bit, and then it is telling me 32. So 31 is 34. Here I go again and make it again. So 34 is bigger than 32. So L1 will be my end vertebra in this case. But I think most of the time we just use our eyes to judge which is the end vertebra, because we just need to see the most tilted one. But if there is any confusion, you can utilize this fancy method to identify the end vertebra. Neutral vertebra again will be as per the, like where we see the, for the lower part, which vertebra shows the spinous process in the center. I think in this case it will be L4. L3 also has some rotation towards the left side. So I think L4 will be the neutral vertebra for this particular case. Stable vertebra. Stable vertebra, to some extent we can judge by looking at this central sacral vertical line. So otherwise the right method to check the stable vertebra is that you have to make two lines parallel to each other, starting from the S1 joint and L5 S1 joint, and I make this vertical line here and almost parallel to this one.
I think by SRS definition, it's the most closely bisected by the central sacral vertical line.
So then, yeah, this is, I think this is a stable zone of Harrington method, I think, yeah, you know.
L4 as a say. So this was the Harrington stable zone.
Yes.
This was the older definition, but now basically you use the most closely bisected by the central sacral vertical line. So this L4 is the stable vertebra for this case.
So regarding centroid of the vertebral body, as we discussed, like one method is that to measure this line, find out the midpoint, measure this line, find out the midpoint, then you connect these two midpoints. Similarly, you make this line on the right edge of the right side of the vertebra, you find out the center point, you create a left side line, find out the center point, and then you make match the make a line connecting these two center point, and this intersection will be the. But again, we don't probably have to be that anal about it. We can just find. I think we can very well guess what will be the center point of a particular vertebra or a particular disc. Let's go to.
Amit, let's pause for a minute here. Ask
Yes.
everyone whether they are on the same page. We can delete all these measurements now, and then start with the next one. So just taking a minute here for everyone to be on the same page. If there is any problem, please put in the chat or unmute yourself and ask if you have not got any of this. So one what I have found out that if you have a long measurement tool like that, then don't measure short. If you go from one end to the other and say 5 centimeters, then you are reducing the error. Instead of putting like a lesser amount, not 5 centimeter, let's say 20 centimeter on that legend. So choose from one end to 20 centimeters, you are reducing error than choosing from one long line to the other long line, which will be 5 centimeter. It's just reducing error, that's all. But I don't think it makes a difference that much. Oh, how do you write text? Amit, how do you write text? Can you please repeat? How do you
So
write?
again, yeah. So basically, you go to this tool section. Right next to the calibration, you will see this text icon. You click on it, and you come wherever you want to apply your text. Suppose I want to type T1 over here. So I click over here. I type T1. I'm not very happy with the position where it's placed. So I click on it, and I can now move it wherever I want it to be. Clear?
I think all right. I think everybody has got it. Let's go to the next one, Amit.
Okay, so next one is we'll go for the upper part of the curve. So let's look at the T1 tilt. So T1 tilt is the angle subtended by the upper end plate of the T1 vertebra, or if it is not seen very well, then the uppermost part of the first rib with the horizontal. So again, we'll take into the account the horizontal tool. So the angle tool will come here. So regarding these measurements, whenever your left side is up, it is taken as positive. If the right side is up, it will be taken as negative. So in this case, we can see that the right side is up, so it will be a negative angle. So I create a line which is parallel to the upper border of the T1. I click over here, and then I make my another line which is horizontal. So right over here, and then I click on it. So angle is 9.2. So the T1 tilt is 9.2 degree minus, because right side is up. Is that clear? Now, one thing we have to be careful about whenever we are making these angles. So let me make this angle again. So I click on the angle, I come here, I make this line, and then I come back here, and then I start making a horizontal line, suppose from here. So right now it's okay, 9.4, but suppose I do it at the upper border, because with the curve we'll have some difficulties. So here it's fine, but with the curve there will be a peculiar difficulty which will show you how to avoid that. So T1 tilt was this angle. Regarding the clavicular angle, again, right side up will be negative. So let's go a little bit on this side. The highest point of the clavicle, which is over here on the right side, will again have to take the angle tool in account. So highest point to the right clavicle, highest point to the left clavicle, and then we can just leave it here. And then we come back. We can the second line we can draw anywhere, and just we have to make it parallel horizontal, and so yeah, so here we are seeing that issue. So this angle is coming 177.3 degrees. So you have to start from one side only, because this time I came from right to left, and then my other line I draw from left to right. So it's showing 177.3 degree, 177.3 degree. Actually, our measurement will be 2.7 degrees. So that's what we would like to see over here. So I go here, and then I clear this horizontal.
Same thing is happening, Amit.
Let's see whether it's happening.
Like
Yes,
that.
you're right. Yeah, yeah. So I think we have to keep our direction same. So it just turned pink. I leave it, and
So just look at the help that is happening. So see, the first click and the third click is on the same side. See, 1, 2, 3, 4 on the help side. The 1 and 3 is on the same side.
angle this one, and then I come over here, and anywhere I draw a horizontal line, and I just leave it. So that's 3.4 degree. So a little bit of measurement error between first and second one. So that's our clavicular angle. Now regarding the shoulder height, the radiographic shoulder height is a little complicated thing. But if somebody wants to, so basically that's the difference between it's the difference between the soft tissue shadow of the shoulder height. So some, I mean, if you have very good X-ray, then you can probably look at it, but otherwise it's difficult to sometimes kind of see the soft tissue shadow over here. But one good way, yesterday we found out, rather than making too many lines, is going to the limb length discrepancy tool. Let's see where it is. Maybe I have not. So see, I did not check it on. So limb length, leg length discrepancy, I click it on, apply, I come back, and where did it go?
Second last.
Yeah, sorry. So I click on it, and then simple, like we can take one point at the very, I mean, it would be probably better to enlarge it a bit so that we get the exact point. And then you come from the very top of the X-ray, and then you draw a line to the top of the acromion.
Amit, first draw a horizontal line.
Not required, Kshitij, because we just need to be we just need to ensure that we are perpendicular to the upper means
No,
perpendicular to the lateral edge of the.
That the tool will only do. If you draw horizontal line, the third.
Okay. Got it. So I think I'll have to go it other way. Sorry, I had not done it before this one. So this is our horizontal line. Then I come here, and from here I click on the top of the acromion, this one, and then I come and click on the top of the acromion on this side. So 28.9 millimeter is our shoulder height difference, with the right side being up. So again, like we are playing with some of these tools which are not meant to be actually what we are doing, but we are just utilizing them to our advantage.
But I think, Amit, T1 tilt and clavicle angle are the two most important ones that you will measure.
Yes.
And T1 tilt tells you the medial shoulder balance, and clavicle angle tells you the lateral shoulder balance. So the trapezial prominence is the T1 tilt, and the level of the acromion is the clavicle angle. And that much, I think, there are so many measurements in this. I think practically this much is enough for you to make a clinical judgment.
So, Amit, how did you make those dotted lines?
So they came on their own. They were dotted on their own. I did not do it deliberately.
Yeah, but which particular tool did you use?
Limb length discrepancy. This one. Can you see over here? Leg length. So it was not there by default. So I had to go into this settings, and I had to select it from here.
Okay.
Yeah.
Amit, we can go to pelvic obliquity.
Yes. So pelvic obliquity, again, like the funda remains same, that you draw a line to the highest point of the iliac crest, and do you draw another line which is horizontal. So 3.4, and other ways of measuring it, you can take this highest point of the sciatic notch also into account. So that's pelvic obliquity. I think that's a pretty much straightforward thing. Limb length discrepancy we have already discussed. Sacral obliquity, like it's a little. Basically, if you really want to measure it, I think it will be too much of measurement. But if you really want to measure it, then you have to take this.
Amit, show limb length discrepancy in this patient from the acetabulum. The tool is meant to be used for the for that. The limb length discrepancy tool.
So that's, I mean, it will basically tell us where the acetabulum is placed in respect to the each other. So that's 12.9 millimeter. Again, it will be kind of one of the surrogate measure of checking why the pelvis is oblique. We cannot go, Kshitij, here, it's not we are not actually checking the limb length discrepancy.
Yeah, we are just taking a estimate. Yeah, it's an indirect way.
Cob angle, the most important one. So again, we have to know our end vertebrae before we will start drawing the cob angle. So for that, you will have to assign your end vertebra, which one is the lower end vertebra and which one is the upper end vertebra. So basically, we have three curves: proximal thoracic, mid thoracic, and thoracolumbar or lumbar curve. So end vertebrae are usually common between two adjacent curves. So the upper end vertebra of mid thoracic will be the lower end vertebra of the proximal thoracic, because that's the most tilted vertebra. And similarly, the lower end vertebra of the mid thoracic will be the upper end vertebra of the lumbar curve. So once you know that, let's see over here, we have already seen that L1 is the lower end vertebra for the main thoracic curve. Now, which one will be our upper end vertebra? So to my naked eyes, I see that 1, 2, 3, 4. I think T5 is the most tilted vertebra in the concavity of the thoracic curve. So once I have decided that, and I know that it will be useful to keep the thing little bit magnified so that you can see your lines better. The other thing, like we are not used to seeing the lines in white. We are used to seeing the lines in black. Other thing which you can do, you can click on this leftmost icon at the lower border of the of your Surgimap, and it will convert it into it will reverse the image. So because we are more used to seeing the lines in black, so I think sometime I use this method to see my lines more properly. So let's utilize this method just for the sake of fun. So after I have identified that L1 is my lower end vertebra and T5 is my, so T1, 2, 3, let's say 2, 3, 4, 5. So I'll click here T5, and here it is. So once I've done that, I click on the cob angle. Now, again, you start from one side and then you draw your line first. And as you can see on the right side help screen, you have to draw your other line also from the same side. Because if you draw it from the other side, your angle will be totally haywire. So we are just doing it for the sake of, so your angle is 118 degrees, which is not true for this particular case. So let's bring it this way. And I think it will be too complicated now. Let's delete it. Bring it again. T5, upper end plate. And L1 lower end plate. And that's a true representative of our actual measurement, which is 63.4 degree in this case. And again, when I want to measure my upper thoracic curve, let's take the T5 lower end plate. And so 29.5 degrees in the proximal thoracic, and main thoracic will be so here basically even L4 is in the curve. It is not yet straightened. So ideally this curve is actually going like this, and it was supposed to end somewhere over here, but that is not happening. So we have to stop at L5 because essentially that is the most tilted vertebra in this concavity of the curve. So we'll take the lower end plate to the L5. And that's our 33.2 degree is the lumbar curve.
Can I ask you, Amit?
Yes, please.
Is this how is the hemic curve described in SRS definitions? All these half lumbar curves, because they are never complete, or even in the hemic curve higher up also.
So can I answer that?
Yeah.
Yeah. So by definition, a hemicurve or a fractional curve where the apical vertebra and the end vertebra are the same.
Theoretically correct, Ranjit.
Where the apical vertebra and the end vertebra are the same is the definition for a fractional curve or a hemicurve.
Yeah,
am I clear?
No.
Yeah, but see, you are right, Dr. Rathod, that these curves are not going to get a full curve. So
yeah, full curve.
We just,
So
we
what
just
do we
cannot
take?
measure them.
So
where do we measure?
you take the end of the spine as your end part. You take the end of the spine as your end part.
End of the spine. So
wherever
probably the lower end plate of.
So if it ends at T1, you take T1. If it ends at S1, you take S1.
Because I usually used to take it as the intercrystal line, or if it is the upper end plate or upper end of the axial plate.
Yeah, so that's fine. As long as there is no sacral obliquity, the intercrystal line, the S1 or the top of the ala is going to be the same.
Okay.
Unless there is sacral obliquity, then only it will be different.
Okay. Okay. No, I mean, I just wanted to know if there is any recommendation from SRS.
So in the manual there were none.
You measure at the end of your curve. So
this is the colloquial SRS. When you talk to any of the SRS surgeon, this is the colloquial definition they say. This was told me by Lenky. This is how Lenky defines a fractional curve. Apical and end the same.
And then he does not mean the end vertebra as the how we define as the end vertebra. It's the end of the spine as the end
of the spine. Yeah, because we always have hemicurves at the ends. We always have the hemicurves at the ends, not in the between. So it has to be at one of the ends.
Yeah. So I think one thing I do differently is that I draw those two lines the same. Instead of drawing two lines at the, say, L1, one at the upper end plate and one at the lower end plate, which essentially it is same because they are going to be parallel. But I kind of keep them same, just.
But by definition, we are supposed to take the farthest end plate of the curve.
It should be the same, but many of the tools will just go 1 point. Within 6 points, you will be able to measure two curves.
Mm-hmm.
So
yeah, Kshitij,
every angle separately.
Kshitij, I also measure it the same way.
Yeah.
The reason being, if you have a double curve, then you don't want to keep drawing extra lines. And the superior end plate is supposed to be parallel to the inferior end plate.
Yeah, yeah. And sometimes whenever you are not able to see the end plate, then you can take the pedicle as the line. So you can take the pedicle marking and then draw a horizontal line if you are not seeing the horizontal of the end plate. So that also is one way you can just judge the, obviously there is a measurement error, so you have to account for that.
You can obviously move these things and you can kind of
And then
rename them.
you can rename that COB2 as PT.
PT.
And
right over
change
here.
the COB1 as MT and change the COB3 as L or TL/L. So that way also you can take it
and you can probably take them away from here if it's too cluttered. Yep.
I think your yellow on white is not visible very clearly.
Yes, so now it will be seen better here. Yeah. Should we go to the sagittal parameters? Anything else, Kshitij, in the coronal plane?
I think one was that apical vertebral translation you can do with the SVA tool. That SVA tool, if you draw, you can just do the apical vertebral translation in an instant.
So there is another tool here, as you can see, this CSVA or SVA. So what you can do, you can click on it, you bring it over here in the midpoint of the sacrum, and you draw a line.
So
like this.
CSVA is the same as CSVL.
And then you can actually, as we discussed previously, that the disc is probably the most horizontal structure in this particular case. So that's the apical, that's making the apex of this curve. So we go to the center of that disc and then we leave the cursor and click outside. So this 72.9 millimeter, as we see over here, is the apical vertebral translation. So that's another tool which we kind of can use. Now the problem which I had found yesterday, that if I use my arrows of the keyboard to go from one image to another, see here, now you can see that this is the first image out of the group of 4. It will go to the third image. I don't know why that happens. And then it is going to the 4, but in another patient I had 9 images, and out of those 9 images it was going to the first, third, fifth, seventh, ninth. I don't know why it was skipping the one in the middle. But so the trick, what you can do, you can click on this arrow right over here, and then it will go to the very next image. You don't have to, you will not be skipping any of the image.
But can we have the larger image, Amit? Possible in this app?
Which larger?
I mean, at least it should fill up the screen, because it looks, usually Surgimap images are usually quite small. Then you'll have to keep on zooming.
I think it will come like by default. See, let's press on this button.
You can actually
make
click
it
on
like
that
a
window panel. You can click on that window panel and zoom with the 2 fingers. It automatically gets zoomed in. Once you start zooming, you don't have to go to the zoom icon again.
Yeah,
this one.
Zoom icon first. Once that mini window starts, then you can.
I think no, but again we are.
Yeah, now you.
Okay, but we are playing in that window only. I mean, the only thing in the screen size.
Now.
Yeah. All these things which are seen over here are coming. Like I don't think that there is any way around. I try to click on these things also. Yeah.
Kshitij, is this the paid version of Surgimap or this is the routine available?
Everything is free.
This Surgimap. Yeah, this is 2.5, 2.3. Okay.
2.3.21.
It's free.
Yeah.
I think just to show the COB measurements on the bending X-rays, when you're doing the bending X-ray COB measurements, take the same vertebra to measure. Don't change your end vertebrae when you are measuring the bend COBs.
Yeah, that is to be maintained always.
Yeah, if you change it, then you are going to only measure the rigid part of the curve.
See, it's now there are a lot of information being hidden here. We are not able to see our T5.
Yeah. So this bending was meant for the left
lumbar curve. Yeah, so we can go over here, but again here we can count from below. 12
for the main thoracic.
9, 7. So this is our T5. Let's bring our curve in picture. That's T5. That's our line over here. So by default, Dr. Rathod, you can see that lines are coming very thin. So I had kind of I went into the measurement settings and I had changed it to thickness 3 because otherwise it was coming very thin.
Yes,
as it's coming right now. So and then so the curve angle is getting corrected from I think 64 to around 22, as we can see over here. All right, Kshitij?
Yeah. If there are any questions, we can pause for half a minute and then go to the lateral X-ray.
I mean, you can put it in the chat box also.
I think the lateral X-ray, this patient's lateral X-ray is not
very good. Yeah, we'll
Can
go to the
Vicky. Go to Vicky. Can you go to Vicky Patel or whatever that name was? I think I had put one X-ray of this patient was a reasonable X-ray for the. Hello.
Yep.
Yeah.
It's opening up, Kshitij.
Yeah.
The shared window is closed. Okay, I did not.
The share has disappeared.
I don't know why. I think it automatically logged out for some reason.
So the lateral X-rays just while he sets it up, it's sometimes quite difficult to measure the proximal thoracic and see the upper part of the main thoracic curve because of the shoulders and the exposure. You really have to have a good X-ray or a lateral view.
I think this one is good, Kshitij.
Vicky had a better X-ray, I think. This also.
No, Vicky has three X-rays and no, Vicky doesn't have the good one. See.
Lateral. Second one.
This one? Okay.
How do you save these X-rays after measurement, Kshitij?
It's automatically saved. Unless you delete it.
No, but where is it saved? Because I had to take the screenshots of those.
It's saved in Surgimap only, no?
Achha, in the same folder.
No. In Surgimap it is saved.
But how do you retrieve it?
You have to go back in Surgimap to see it. Or you take a screenshot and keep it or export it.
Hani, abhi tak to then like I've been doing that only.
You can take screenshot and keep it. It's not happening.
I don't know why it's like all the images are opening simultaneously.
You can pick another patient.
Now, yeah, I think import and then import the film. Yeah.
So by convention, we'll want patient to be seeing to the right side of ours. So let's have a look at the SVA. C7 is not very well seen here, Kshitij.
It's going to be hard.
Yep.
Many times I don't do these measurements like very religiously. I don't know. Dr. Arvind, do you do this like religiously? I mean, I'm just taking ballpark kind of visualize it and go forward. Dr. Ranjit, what do you do?
So I try and measure, but no, I measure with the iPhone app. Try and measure whenever possible.
How did you flip your image?
Flipping is by this. You see here these two icons. One is for to flip it vertical.
Yeah.
And this one is for horizontal.
Okay.
Yeah.
So it is the vertical one.
No, it was facing to the left side, so I converted it to facing to the right side of me.
Kshitij, can I ask you a question here?
Which icon, Amit? Which icon?
Yes, lowermost you see these two side by side facing,
okay,
or this
this
up.
is
Yeah,
up,
these two.
up. Okay.
Yeah. Ranjit, go ahead, please.
Yeah. So, how do you get your T2 to T5 kyphosis measured? Because one of the criteria for proximal thoracic structuralness is a T2 to T5 kyphosis. Now, I always flounder there. How do you get it correct? T2 to T5 kyphosis measurement.
I think it's very hard. You need a really good X-ray for that.
Okay. So the same issues. Okay.
Because most of the time what happens, like you can see this patient's hand is not positioned properly. The patient's hand should be in front of the shoulder, not on top of the shoulder.
Should be holding the clavicle.
So it should be, it should be on the clavicle and it should be in the front.
So now what we have kind of moved over, we ask them to hold the ears now. Hold the opposite ear. So that's what we do. Or hold the opposite ear behind the back, So the PT becomes more clearer. We're trying it out. All the lateral x-rays, instead of in the front, you ask them to hold the opposite ear across the head.
But Ranjit, does it make it a bit more clear, T5 and all this?
Yeah, so with that, we are getting more and more clearer because, like we'll be having the discussions like Dr. Kshitij said in the classrooms. The most important thing for proximal thoracic or shoulder imbalance is a pretty structuralness. Wherever I have got post-op imbalance, all those T1, the thing is that I missed the PT to be structural because I just looked at the coronal plane. I missed the sagittal plane. So when I go back and look, I missed the PT structuralness because of improper measurement of T2 to T5 kyphosis.
Yeah.
So Ranjit, you ask the patient to bring the hand from behind the head?
Yeah, so behind the head, ask them to hold the ears. जैसे ऊपर लेते ना यार बहुत हो जाएगा.
Yes. But will that not stretch the spine? Like will it not put the spine?
It is actually not. See, the only thing is the patient should not bend the neck. You ask them to stand straight and hold the hand behind. So that takes the shoulder out. You can see it better. Especially in a pendulous thing. You can really it's much more clearer. Not the perfect way like an EOS, but still it's better.
Okay. So regarding SVA, basically what we need to do, as it's shown over here also, that we have to find out the C7 centroid in the lateral view, which.
So what is the SVA, Amit?
Sagittal vertical axis. So how much is the body kind of falling behind or to the front? So that's the a line subtended from the center point of the C7 body down. So the posterior superior corner of the S1, whether the line is falling to the front or to the back of it. So that will determine whether the body is imbalanced in terms of the vertical axis. So for that, this tool works very well. So assume that we'll have to assume a bit that C7, we can see this shadow of the cervical spine, and assuming that C7 vertebral body is here. So the first thing is that we will have to, draw this line from top to bottom. And see, the line is very thin. I don't know whether you guys are able to see it also or not. But
we can see it very well. Yeah.
Okay, very good. Thank you. Then so it's almost, in this particular case, it's probably 0.4 millimeters, almost 0. So that's the way of measuring the sagittal vertical axis. I think the one important thing we would like to measure is the pelvic incidence. So that tool will be very handy.
So the other problem with the SRS definitions of these side views, actually SRS definition is different. It's from the end vertebra to end vertebra. It is not from T4 to T12 or T5 to T12. It's from the end vertebra of the upper kyphosis to the end vertebra of the lower kyphosis. So everybody doesn't have the same sagittal profile.
Yeah. So this is as per the Lenki classification.
Classification, but this is not like, this does not mean that the true kyphosis is this much. The true kyphosis of the thoracic spine is from the end vertebra
end to end
spine to the end vertebra of the thoracic spine. But this is just to make the classification more reliable and have a better inter-observer variability. Otherwise, people will just start measuring whatever they feel. So to have a consistency, I probably did that way. And I think more than the main thoracic kyphosis, you are measuring proximal thoracic and the junctional areas you are giving some importance to than the other.
Yeah, I think that is more reliable, as Kshitij said, no? It's from end vertebra to end vertebra. And if we have a particular kyphosis or hypokyphosis, say junctional area, DL junction, and then that should be counted. Yeah.
Yeah. So pelvic incidence, Amit?
Yeah, so let's play with this tool. So you click over here and so I'm measuring the first part of the femoral head, either one of them, and then I select it and then I let go. Then I go to the second one and it's over here. So most of the time we'll see them that they are not overlapping. So it will have to kind of average it out. So there's a sacral end plate.
Are you able to change the color of the line?
It is automatically happening.
It automatically happens.
No, but no, I'm not doing it. But I think in the settings you can change the color of these
because
lines also.
Sometimes on a white background, no, it becomes a bit difficult to appreciate yellow.
You just make the line thicker. That's all.
Achha, that's the only control we.
Sorry, I think I kind of missed one of the point. Sorry, I'll go back.
Follow the what I will say tell the delegates is follow the help. The help is very good in Surgimap. Tells you exactly where to put your clicks.
So here we go. We got everything over here. Our PI is 28.3. Lumbar lordosis is 32.2 from L1 to L4. And PILL mismatch is 32.6 degrees.
How did you calculate this, Dr. Amit? Can you please tell us?
No, I did not calculate. The software did. I just.
Amit, you can describe the steps.
Okay,
Just
sorry.
Loudly.
So
Yeah,
basically,
do it again. Yeah.
Okay. So basically, for this one, what you need, you have to you need to have these femoral heads into the picture. You need to have your X-ray going down to that level. You click on this PILL icon. Then you have to, first thing is that you have to, it will draw two circles around the femoral head. So first circle you click, and then from the edge of the femoral head, you kind of draw your first circle. It should be encircling the femoral head. Secondly, I click on the edge of the femoral head, second one. And once I click on that, it will, like I kind of move my cursor. Then it will encircle the second femoral head, and then it will take into account this center point over here, because both the femoral heads are not overlapping. So it will take into account this line, the center point of this line. Then the anterior corner of the S1 and the posterior superior corner of the S1. That's done. Then I have to go to the L1, and
You chose which measurement for the S1?
that's the upper end plate of the S1.
No, with line measurement or which one?
No, so it's part of the same tool. It's everything
Okay,
is part
same
of the
tool.
same tool.
Okay.
I'm not going to any. I'm not going and selecting new tools for every
Okay.
step.
It means only one tool you select it.
Once I selected PILL tool, it's giving me that two femoral heads. It's giving me 6 points actually, 8 points rather. 2 points for the first femoral head from where I start and where I end. Third point where I start the second femoral head, and fourth point where I end that circle. Fifth point, like as Kshitij said, it was very useful for even for me also to kind of have a look at the help. It was kind of shown very clearly. Fifth point is yes.
Yeah. Any reason when I click my PIMS tool, it does not get selected. Any rest all get selected. Anything to enable? It's already enabled on the.
So Ranjit.
Yes.
Ranjit, what is happening is that you have to first define what is the front and the back of the patient. So you see, Amit, can you show him the face? Which X-ray are you using, Ranjit?
I'm using one of the Vicky Patel lateral ones. That's what I had. So I'm using it.
Can you guys see this icon over here? It's that like an emoji.
Okay.
So if I click on this, you'll see that now it's the guy is looking to my left. The eyes, the hair are on the back. There's the head of the guy.
Okay.
And now it's looking on the right side.
Yes, got it done.
Now
Okay.
the software is quite intuitive. It's not otherwise, like in the AP X-ray yesterday when we were playing with it, it was showing all four things: front, back, right, left, right side facing and left side facing. But today, I think it has kind of found out that we are playing with a lateral X-ray. So it's showing me either left facing or right facing. It's not showing me the other thing.
Okay, got it.
Other thing you see at the bottom, when I change it, the angles are changing to minus to plus and plus to minus. When I click it, so I'm making it face from right to left. All the angles below are changing their like they're going into the negative value.
Okay, perfect. Excellent. Thank you.
So, life is simplified, Ranjit.
Yes, please.
Amit?
Yeah.
Yeah, so Sandeep here.
Yes, thank you.
One question is that these parameters, once you mark in a particular color, if there's an abnormality, do they tell us by some color coding, or are these age matched once you feed the age of the patient in the database?
I think there is Kshitij, you want to elaborate on that?
Answer that. Yeah. So there is. So if you see, you have to put in, if you don't have a calibrated image and the DICOM does not have that information of age, it allows you to put the age, and in the measures table, which is the third section, you can see the measurements and the age normative measurements are shown there. You see the measure. Can you open the measures table, Amit?
Right. Yeah.
See open it. Just double click on it. It will open. Means it will be a free window. Or you can drag it somewhere. It will be a free window, and you can enlarge it. Anyway, that's all right. So the red colors, the red ones are the abnormal ones.
Okay.
It gives you the normative data and it tells you what the abnormality is in red. The orange is somewhere in between and the other color is okay. And this is not normative data according to the age. If you put in the age of the patient, or if the software knows the age, it will give you the age related normative data also. But that's for adult deformity. For these AIS, I don't think we are looking at that. But yes, you can. It already has a inbuilt normative data according to age, and it is telling you pre-op measurements. You can do a virtual surgery like a PSO or something, and it will tell you post-op measurements as well. Like you can do a virtual surgery, but probably we can't do that today because that's a topic for whole another day.
Thank you.
Double click the side, the two lines.
All right, what's next? Kyphosis.
Are we anything remaining? I think we are done.
Kyphosis is there, but that will be like
kyphosis, yeah.
Yeah,
it's
so
the same as the angle measurement.
It will be like a curve angle measurement,
yeah.
or your angle measurement for that matter. So we have to choose our right vertebrae. So we take this L2 here, and see here again there is some amount of obliquity. We are not seeing them end on. Assuming this is T10, we measure that, and then it will tell us the amount of lordosis or kyphosis. So it's 3.6 over here.
I think now that perpendicular method is discarded almost, since after this all this, right?
Yes.
yeah.
Yeah, but if we are doing it on the X-ray, then we have to do it, like by manual. We have to know it, and we have to do it that way only.
Yeah, that is provided basically the lines go out of the X-rays.
Yes, exactly. But I think most of the time they will, because X-ray, the side-to-side X-ray has very limited dimension, and we don't get those 100-degree curves all the time, where the lines will match very, very soon. Anybody has any question or anything in particular they would like to know?
So I can show MPR finally, and then we can end this. Correct?
Does this have MPR? Surgimap?
Yeah.
Like Osiris?
Yes.
I just show.
So I'll just share my screen. So if you cannot do it unless you request for premium features. So you can request for premium features on the website through your account. And that's how I got the premium features, and I haven't paid. Now, hopefully they have kept it free even now. So we'll go to one CT scan, which is this patient, and we'll load up the CT scan. That's the CT scan. It's not like Horos. If some people are using Horos, that's like really powerful, and I wouldn't recommend you use this if you have Horos, but not everybody has a MacBook. Some people are using Windows computers, and this is kind of a slow version of doing it on this. So if you have loaded up the CT, you can load up the MPR by those 3 dots here. There are 3 dots here, and my computer has gone really slow. And then, sorry, not those 3 dots. It's the 3 lines here. Sorry, my mistake.
There's a lot of disturbing sound. Someone's
really slow. Especially if you have a lot of data, the CT scan, then it's not very fast. So you see here there is MPR here, and some of your Surgimaps may not have it because they activate this only if you request for a premium account. So you activate. MPR stands for multiplanar reconstruction. So you can reconstruct this CT scan in multiple planes and see it. I guess I won't be able to show because something is wrong. This is just taking too much time. But yeah, so it has started, but it's not as fast as Horos is. But yeah, while this loads up, if anybody has a question, we can take it. So if anything we have missed.
I find it difficult even in the Horos also. I had Horos, then ultimately gave up, and then I do it even on my hospital computer on the console.
So then it's time to change your computer, sir. Because Horos is really fast. If anybody among the delegates using Horos for planning?
Is Horos also been acquired by Osiris now?
No, Osiris became paid version. So
No, but because like I was trying to download it on my another computer, and it was giving me some difficulty. It was showing that like Osiris name was also coming along with the Horos. So
no, it's separate. Horos is completely open source. So I think I'm going to stop. Oh, sorry. As I stopped the screen share, it automatically started the MPR. Let me start again. So this is the MPR window. If you can see, this is the MPR window, and you can take your CT scan, these lines you can draw, get them parallel to the end plate and see your pedicles. So you can turn these axes into their parallel to the end plate. It's not as pretty as Horos, but it can do the job. There, if you can see, I'm moving the axis so that I am perpendicular and parallel to the end plates, so that I get that pretty picture of the vertebra in its true anatomical plane. And if you scroll these images, actually you'll get a true axial of this vertebra. So I'm getting a true axial image of this vertebra. I can go to the surgical tool list. I can go to the surgical tool list, or I can go to the, sorry, I can go to the surgical and the screw here. You can see there is a screw here in the tools section. Click on the screw and then draw your screw from wherever you want to place it and increase its thickness to get the diameter. So you can see that this screw is going to be like 31 millimeters and 3 millimeter diameter or whatever. So that's how you can do screw measurements and look at the pedicles, how they are. This is useful only for a bad deformity. For your typical AIS patient, you're not even going to get a CT scan done. So I think that's about it. I think we have used up our time, and
I think that was pretty nice, Kshitij and Amit.
Thank you. So
yeah,
we will share this recording on the classroom, so you can review the. If you want to go back and practice, you can see the video and do it on your own as well on the Google Classroom. All right.
Yeah. Okay. Yeah. Thank you.
Okay then. I will see you all tomorrow at 4 o'clock for the main part of the meeting.
Thank you, Kshitij and Amit. Good evening, and it was a great time.
Thank you,
See you
Dr.
tomorrow.
Thank you.
Thank you.
thank you guys. Thanks a lot for being here.
Thank you.